Welcome back to the Prescription Press. I'm your host, Dr. Nolan Fisher, and today I have a very special guest for you. His name is Dr. Jimmy Bowen, and he was the team physician at my university whenever I was a college baseball player. He's the reason that I got into the branch of medicine that I am in called physiatry, and he's been a close friend and a mentor to me. Now, Dr. Bowen has had a long career that's gone from the Navy to private practice in sports medicine and now to longevity specialized medicine. In this podcast, we discuss his background, why he got into the field of medicine that he did, and why he is currently practicing in the style of medicine that he practices now. We're going to get into things such as longevity, how we can prevent the 4 major killers, and what we can do to be proactive so that way we can live longer and be healthier for all those years. Finally, we'll get into some actionable steps that you can take away from this podcast that you can apply to your own life. Now, let's get into the show. Welcome back to the Prescription Press. I'm your host, Dr. Nolan Fisher. I am joined today by a very special guest. This is Dr. Jimmy Bowen. He is from Cape Girardeau, Missouri. He graduated from Southeast Missouri State, my alma mater, and then he went on to Mizzou for medical school, PM&R residency at the Mayo Clinic, and then he was in the U.S. Navy for 24 years, I believe. At one point, he was the U.S. Naval Academy team doctor. After that, he got out of the Navy and he came back to beautiful Southeast Missouri, Cape Girardeau, practiced at a couple places there, advanced orthopedic specialist and Southeast orthopedics and sports medicine. In October of 2022, he moved on to the next chapter at Fountain Life in Florida, which I believe is outside of Orlando. Mm-hmm. How I met Dr. Bowen, he was our team physician while I was at Southeast Missouri State University, where I played baseball at. Was a huge reason why I even went into medicine in the first place. Whenever I was a junior there, I shadowed him in his clinic. I got to see all the cool things that he was doing, the people he was taking care of. And I said, I have no idea what this guy's job is, but I want to do it. And the rest is history. Now, 10 years later, I went to physical medicine rehabilitation residency as well. And it's come full circle. So now that I'm coming out into practice, I'm of course talking to Dr. Bowen, learning a lot from him. And I think that he would be someone that the listeners could learn a lot from too. Dr. Bowen, would you like to add anything to that intro?
Well, I let you know after internship, I had a gap before I went to PM&R because I actually was a flight surgeon in the Navy and did aerospace. And then I actually moonlighted at Kaiser in San Diego and got a background in emergency medicine for about 4 years. So
wow.
I was a little delayed going to residency and I was looking for a place to do sports medicine.
Mm-hmm.
And I went to the American College of Sports Medicine meeting and met 2 physiatrists doing a talk on how to examine the back. And one of them was a team physician for the Seahawks. And so Stan Herring and Andy Cole, and I had no idea. My experience with physiatry was a couple of foreign medical grads doing an EMG on a Missouri farmer. And there was no English spoken by any of those 3 that I remember. And a lot of confusion. And I remember saying, I don't know what I'm going to do exactly, but I know what I'm not going to do. And that's that PM&R stuff. And then, of course, once I fully found out what it was, just an amazing specialty.
Yeah. And the whole premise of the specialty is to restore people's function. And so the most beautiful part about physical medicine rehabilitation or physiatry is that your incentives are completely aligned with the patients. And
Correct.
whenever you make them better, they actually feel better. And so that was one of the things that I noticed whenever I was in your clinic was that all these people were so happy to see you. A lot of doctor's visits aren't very happy experiences. And I was like, this is something a little interesting. This isn't like my experience going to the doctor as a kid. This is fun.
Right.
And again, sports medicine, you were an athlete as well.
Mm-hmm.
You were a sprinter, right?
Well, sprinter, and I did some wrestled briefly in college. Nothing. I had the realization that wasn't going to be my future. I know you played baseball 4 years. But definitely, I left school. I started University of Georgia and then moved to SEMO. Um, and little did I know it had the highest rate of medical school acceptances of any place in the state of Missouri at the time. Great med program, and so I was fortunate enough to land in the right place for me because I knew I wanted to be a physician.
Yeah. And I kind of had that same feeling too. The only thing is, I didn't realize as soon as you did that I wasn't going to be a professional. So you were a little smarter there. But when I went to SEMO, it was almost entirely off of baseball, and the connections that got me into medical school, meeting you, and also knowing people up in Kansas City that allowed me to have a relatively straightforward path to get into medical school, which isn't normal. And I
Correct.
found that was so funny is a SEMO is a state school. The acceptance rate is very high. It's not like it's hard to get into, but for it to
Yep.
have such a good pre-med track was really interesting. Now tell me this: did you, when you decided to go into PM&R, did you realize the breadth of the specialty, or
No,
were you basically thinking, "Oh, this is my key to get into sports medicine"?
it was mainly this was my key to get into musculoskeletal and sports medicine. And I'm an allopath or an MD.
Hmm.
And of course, we have very minimal exposure to musculoskeletal medicine. But I was looking at family practice. I was looking at internal medicine, sports. I was trying to find a conduit to get into sports medicine. And I was covering some teams, high school teams and things in San Diego that I took upon myself to do. So I was interested in that team concept. And as a flight surgeon, you take care of a squadron.
Hmm.
And so you're taking care of the pilots. And we had a helicopter squadron, so male and female, and then their significant others. Obviously, you
Hmm.
can't separate that out. So I was already a team physician in essence because of being a flight surgeon.
Yeah.
And I like that concept because obviously physical health is part of it. Mental health and emotional health is a huge part.
Hmm.
Um, and I like the complexities of having to deal with all of it.
Yeah.
Uh, and then meeting the right people. I mean, I wasn't going to do physical medicine rehab. My experience had been negative when I was in medical school.
Yeah.
And then I found out there were all kind of people that were doing very different things. The breadth is huge. I'm not sure any physiatrist is exactly the same as the one next to him.
Yeah.
Um, and then I was there during the schism of physical medicine and rehabilitative medicine.
Hmm.
Um, and so they joined back together, but the advent of going towards outpatient physical medicine and not just inpatient rehab was huge.
When I got into it as well, I was thinking more from the outpatient perspective. Learning about the inpatient rehab is a whole different aspect. For those of you who don't know, inpatient rehabilitation takes patients after they've been hospitalized for a variety of different things, but most commonly strokes and brain injuries, spinal cord injuries, extremely complex medical conditions where they're just not safe to get home. And
Hmm.
we want to make the patient functional, and we want to get them home, and we want to do it in a timely manner. And what's amazing is the rate that we can do that through directing rehabilitation programs, something that's actually somewhat at the core similar to sports medicine, but in a
Hmm.
very different performance type type of arena. Instead of
Correct.
young athletes, you're looking at older people who their event that they're going to get back for is to be able to walk into the kitchen and take care of themselves.
So we talk about impairments, and we don't want people to be disabled. And the difference, of course, is an impairment is something that's measurable that you can't do, but a disability means you can't take care of yourself in society. You
Hmm.
can't, financially or otherwise take care of yourself. And the goal is always to prevent people from being disabled and athletes from being disabled. Impairment doesn't mean you can't come back. And so that's the goal. So that was what was fun about it is you get to see people on the other back end and you can see a tangible thing happen, which I'm
Yeah.
not sure that we always do in medicine.
No, no. Well, so whenever you left the Navy, that would have been 20 some years later.
Yep. Yep.
Was it hard to leave?
Yeah, it was hard to leave. I mean, I left when it ceased to be a joy.
Hmm.
And it seemed like there's that I had 24 years in, so I'm into my 40s. do I wait too long and transition out?
Mm-hmm.
Do I do it where I can do another 20 or 20 plus years? I was thinking if I did retire in the 60s, I would want to have a practice that was, at least a couple of decades.
Mm-hmm.
Um, my son was being recruited to play football at SEMO.
Mm-hmm.
I was in Memphis, and I came back there and sat in the stadium there and was like, I always loved Cape Girardeau. Cape Girardeau, if nobody's been there, that's the boyhood home of Rush Limbaugh. It's a little, it's a little city, 38,000 people that doesn't know it is.
Yeah.
It's got two fairly large hospitals. Between St. Louis and Memphis is probably the medical mecca of the area. The Drurys, who own a bunch of hotels, are there. There's a lot of industry, so it has all the attributes you would want in a city, but on a smaller context. Um, so that you don't want much for much, and then it's completely surrounded by farmland, which is very similar to Rochester, Minnesota. If you've ever been to the Mayo Clinic, and the mayor of the town when I went back there was actually from Rochester, Minnesota, and that's one of the things we used to say, that this was the Rochester South.
Yeah, makes sense.
Mhm.
It's just a
Yeah,
great place too. A great college town. Like, got kind of everything you need with a small town feel, close to St. Louis in case you need, the few things that aren't there. It's
correct.
honestly a great place. I can imagine it's a great place to call home for a while too.
It is. It is.
Yeah.
And if you need barbecue, Memphis is not that far away. And in deference to Kansas City,
Yeah, exactly.
barbecue is
Yeah.
good at both places.
So
Yeah.
when you went from the Navy to private practice, were you surprised at how different the practice of medicine was, or
Yeah.
did you feel like there was a lot of similarities?
There was many of the similarities. And I was cradle to grave in the Navy. I used to do
Hmm.
a special need children's clinic with some pediatric orthopedic surgeons. We didn't have that.
Yeah.
So now it became more of a later teenager to grave kind of
Hmm.
group. There was much more pain and much more work comp than I had imagined. And of course, every day in the Navy was work comp, but it was on a controlled environment.
Yeah.
So that was more than I anticipated. And then I basically ate at the buffet. The idea is I'm not sure what I want to do yet, so I was going to eat the whole buffet and then kind of narrow it down. But I kind of like everything, and I was that way with medicine in general. Is there wasn't the things I love, I may not actually want to do as a career. Like OBGYN was my favorite, but there's no way I want that as a lifestyle. Um, but there was, I had a wide breadth. So, I could see a 15-year-old that was just injured in the sports, and then I could see an 83-year-old who was falling down and had had a hip fracture and how to keep them going. So, every day was a mix, and it was fun.
I kind of felt the same about emergency medicine because that was my second favorite one. The idea that anybody could walk in the door with any problem, you had to solve it. That's a fun part of medicine. As far as the lifestyle and if I wanted to do it for the rest of my life, I don't know. I don't think so. But at the end of the day, I thought it was super fun.
I agree. It's an
Yeah.
adrenaline rush,
Yeah,
and
absolutely.
if you like chaos, and the great thing is you learn to be very calm during chaos and be very focused, which is again what's joyful. But if you're OCD, you worry about everything you did when you leave, and then it's tough to get mobilized to go in there. Once you're there, it's fine, but I find that it's really tough, and there's no great follow up.
Yeah.
So you don't see people on the back end and truly know how they turned out.
Yeah, the people you get to know are the unfortunate few. Let's
That's
put it
correct.
that way. Yeah.
That's
So
correct.
so then you go from Cape Girardeau and you're doing sports medicine, you're doing what you've been wanting to do. You've done it now for 25 years, 30 years at this point,
Hmm.
and you change paths and you end up with Fountain Life down in Orlando. Just a little background on Fountain Life. I like their mission statement. I saw it on the website and I thought it seemed to wrap up a description of what you guys do. It said to transform the current healthcare system into one that is both proactive and data driven enabling us to boost longevity and catch and treat illnesses earlier than before.
Correct.
So what led to you going to Fountain Life?
I don't believe many things happen on accident. And so literally I had a dream that I needed to go to a certain restaurant in town. And the next morning, my wife and I were choosing where to go eat. And I suggested that she doesn't like this restaurant. It's not a favorite of mine. And I said, I don't want to eat there either, but I'm supposed to be there. And I have no idea why. So we went in there, and there was a guy named Jim Limbaugh, who's a cousin for Rush Limbaugh. And I knew him. He was vice president of our hospital. He's a bank president. And he was leaving as I walk in. And he said he had just been down to Naples, Florida. And there's a guy named Bill Capp. Bill Capp is the CEO of Fountain Life. He used to be an orthopedic surgeon in Cape Girardeau. And we went to competing high schools in Atlanta. And he said, I just went down there. I got all this workup. They were looking at all these different things, and I got some stem cell treatment while it was there. And I was like, Jim, we do that right here. And he goes, no, no, this was different. So I literally got on the phone and text Bill and said, Bill, I'm proud of you. I know that you're in business with Tony Robbins and Peter Diamandis now, who I was aware of. I said, you've done more with the Georgia public school education than anybody I know. It's a joke. And what I got back was, we need to talk. And so he has a office still for business interests in Cape, and he has a house there. And so he was back on that Thursday, 5 hours of meetings during my administrative morning. Actually was late getting back to clinic in the afternoon, and he was telling me what they were doing. And I was like, that's what I wanted to do. And, I'm 61, almost 62 at the time when I'm talking to him. And my first thought was, oh, I don't want to retire. I want to go do this. I want to do this until I can't work anymore. And the idea of having preventative medicine where you can catch things early, the idea of democratizing that and hopefully changing insurance so that we can get people doing this early on, so that we can increase their well span or their health span. It was very different than what I was trained to do. It was looking for the whys as well and maybe treating those. And the whole goal, of course, is to get you to die as young as possible at an old age.
Yeah.
Is what we want to do. And so that's kind of the mission. And the biggest thing, though, is also to get the insurance industry to recognize that this is the best way to go financially as well as physically for the people that you're insuring.
Yeah. So traditionally in medicine, it's a very siloed approach to the body, right? You take the bones, you divvy them up, they're with the orthopedic specialists.
Mm-hmm.
You take the heart, the cardiologist manages that. The kidneys crucially work together with the heart, that's a different physician.
Correct.
So all of a sudden you have this siloed approach that is focused on don't do anything until something goes wrong, and then we're going to patch it together. And then we're going to send you back out there, and we'll pray the wheels don't fall off. But when they do, we'll patch it back together and keep you going. This is very different.
Mm-hmm.
This is all of the work up front so that you don't have to do the work in the future. You mentioned health span.
Yes.
How does health span differ from lifespan?
That's a good point. So obviously right now we see in our current system that people live on average to somewhere in their mid 70s. Actually, if you take away COVID and some death around birth, it's actually in the early 80s is what we see. And men and women are not that far disparate. They're about 83 and 82, but you spend 25 years of that being sick, basically not able to get around, just getting through day to day. If you retire, you're not active as much. You're taking a sundry of different medicines just to keep going. So your well span is you don't have to do that. You can get up and go. You can move. You're not taking a bunch of medicines to control what physical ailments that you have. And of course, polypharmacy, you got multiple doctors giving you multiple things, not concerned many times about the interactions, which also may ruin your health span. Yeah. So the idea is, can we improve that? And just from an existential point of view, we want people to be healthy their whole life.
Yeah.
right? And then, you die whatever age that is, which I'm not sure we know the top end of that.
Yeah.
Um,
And I think another important statistic, you mentioned that the average person, if you take away COVID and you take away some childhood illnesses, is 83. But if you are somebody that's 60 years old, I believe the statistic is on average you live to like your early 90s.
well,
And so
definitely, if you live to 70 or 80, you're definitely going to live more than half of people may get to their 90s.
yeah, yeah, and that's because you're taking out things like traumas, like car accidents that kill young people,
Right.
unfortunately suicides and homicides and stuff like that bring down your expected age. And then of course some of the middle life diseases, if you get past those, then you
Hmm.
have less of those as well. But the last 10, let's just say the last 10 years or the last 15 years, from 75 to 90, even if you're active, I think traditionally we think about those years of people in wheelchairs with walkers, with canes, barely getting around. And those are a 15-year chunk that with our current practice of medicine, we have not done a good job
Oh, in
ensuring
fact,
that
the
that's
attitude is, you just need to suffer that. That's what happens when you get old,
it just is what it is, right?
is what it is.
Yeah.
And we
Doesn't
can
seem like a
argue that
good
that's
solution to
not the right
anything.
attitude, you
Yeah.
know?
Yeah.
So, think of all the ancestral societies where the elderly were held in great reverence, and many times were, fairly healthy people. Um, have that. We're disposable when we get old. And the attitude in the sick care system very much is, well, this is what happens, and you should, I know you hurt everywhere, but that's what happens. Right. So you're supposed to be happily discontented for 15 to 20 years? No, no. And that's more a reflection on our medical system than it is on the people that are
Yeah.
receiving the care.
Absolutely.
Yeah.
And it's unfortunate, but the thing that has resulted is us saying, all right, let's get outside of that medical system, which seems to be more of where Fountain Life is at this current point.
Correct.
They're the unfortunate thing for getting outside of the system is that at the initial steps it is extremely expensive.
Correct.
But with the rapid increase in popularity, and especially like the baby boomers, the generation after getting older, what we've seen is this area is becoming flooded with money, which is going to bring resources and drive the price down and make it more accessible. And so I
Absolutely.
think we're just this kind of field of expanding the health span is really just starting to flower, and it really seems like it's going to turn into the foundation of the sick care system, whether the sick care system wants that or not.
Right. And so, and again, you can, if you did it in practical terms as far as money, and right now our sick care system is running based off of treatments that get money. So why would they want to find cancer early? You know, when you can treat it before, wouldn't it be very simple to treat it, right? And not costly. And that's financial, emotional, however you want to conclude the cost. But I think it was, and I'm sorry if I'm wrong about this, but I think this is attributable to David Sinclair, PhD from Harvard, who's an anti aging doctor who does a lot of research with that. But I think he made the comment that if we could increase the well span of everybody in the United States by 1 year, it would be worth about $20 trillion to the GNP of the United States.
You
So
know
$20 trillion.
that reminds me of the statistic about how Walmart increased the gas mileage of their semis by 1 mile per gallon, and it saved them like I don't even know $1 billion or something like that in operating costs.
Correct.
It's kind of a crude way to look at human beings as money. But what you're saying is if we make you healthier, what we're doing instead is you're taking up fewer resources that then can be deployed to other things that are also important.
Excellent
And
way to put
and
it.
it's an approach to medicine that makes sense. The fortunate part and unfortunate part is that our medical system has gotten so expensive that it's going to force this change to happen. Let's talk about Peter Attia for a second,
Okay.
because I would imagine you're a fan of his work as well, because I loved his book Outlive. I think it's fantastic. This is a part of your practice, I'm sure, would be the four horsemen that he talks about. And the
It
four horsemen are the most common reasons for death, right?
correct.
Yeah. So we
Correct.
have
And
I have them down as heart disease, cancer, neurodegenerative diseases, and then type 2 diabetes or metabolic dysfunction in general. Are these the primary preventative focus that you guys have with Fountain Life?
so we have the preventative focus at the start. So and very much like he has, we have a cancer health journey. The next we have is a heart health journey. We have a brain health journey is right before the heart health. And then we have a metabolic and musculoskeletal sort of health as well. And then we get from there into, optimizing of other things, hormones and things like that, trying to improve your biologic clock. But the biggest thing are those big areas of four horsemen. And obviously, heart disease is the number one killer of people in this country and industrialized world. So how can we believe that heart disease should be an orphan disease, but that means you have to identify it early. And of course, Peter Attia started when he was about 38. And if people don't know his history, he was going to be trained to be a cancer doctor. He was a general surgeon. And then he kind of had an epiphany about his heart health relative to his relatives. He actually left medicine for a while.
Yeah, he
I
went
believe
into consulting, I believe, with like McKinsey or somebody.
think he was or an actuary for an insurance
Oh,
company or
that's right.
something like
Yeah,
that.
he was an actuary. Yeah.
And then he had some interest in obviously math and those sort of logical pursuits. And then he ended up coming back in the space of anti-aging medicine. And the thing I appreciate about Peter Attia is that he is also mindful enough to reconsider what he believes.
Mm-hmm.
So you'll see over time him kind of evolve to where he is now, and we can talk about. And he's very much into nutrition, strength and conditioning, those aspects of it as well for health. It isn't just feed you a statin drug for heart health, although there's a place for that. But the first thing we do is try and identify where you are on the spectrum of healthy versus not healthy.
Mm-hmm. And what's that? What is the way of doing that? I mean, there's basic metrics that people talk about with heart disease, right? There's your LDL labs, your HDL, there's your blood pressure. Do you guys go a step further as far as like CT, calcium scores, or
It's a good
what's the
question.
strategy that you have for um, kind of seeing where somebody is at when they come to you relative to their risk of heart disease?
So if we started off with heart health, first of all, we're going to get very granular with the labs. And so we actually get down into the size of your bad cholesterol. And we get into the balance of whether you're overproducing cholesterol from your liver or you're absorbing more of the cholesterol. So we do that with a company. We use Boston Heart, and they do a very good job of that. And so we can tell you how much of your bad cholesterol is small and dense. Well, now why would that be important? So imagine the inside of your blood vessels are kind of like a hair-like network, or almost like a tennis net that keeps cholesterol from joining onto the inside of your blood vessel. Well, if you had BBs and you were throwing it at a tennis net, a lot of those BBs would get through. Those would be the small, dense cholesterol. If you had big, fluffy beach balls or softballs, they're not going to get through the net. So we'll look at the percentage of the small, dense bad cholesterol. We also look at the mechanism the bad cholesterol gets to tissue, and that's going to be the phospholipid called ApoB. And so we can look at that. So traditionally, now when I was coming up for school, 250 for total cholesterol was normal. We developed statin drugs. Then all of a sudden it was 200. Then, now it's do we really pay attention to the total or are we more invested in the components of it? And now that's what we've done. And so overall, we look at all of those and how do we implement a plan? much of it is nutritional, and especially if you're young enough, it can be behavioral modification, but we don't see behavioral modification later in life as being as effective. And so we get involved with the use of medications. One may be a statin, it could be something to decrease absorption, it could be nutritional that can do the same. Um, Simple things like aged garlic extract can actually help your heart. It can help your blood sugar. Um, and we approach it knowing that it's a biologic system where everything interacts with everything else and not just focus on the heart.
Which
So,
makes sense.
you're right.
It's
And then
the anti-siloed approach,
it's
right?
the
It's the whole
anti-silo approach.
yeah,
When I was in school, we had a bunch of siloed courses that we took, and then you were supposed to put it together later on. When subsequent to that, they did organ systems where they took the liver and they did all the different pharmacology, they did the histology, everything that was related to. And now the idea is the liver doesn't work by itself. It has biologic influences from everything else. And how do we make it optimal? And now we also throw the genomics in there, the genetics of what you may be preloaded with, and how do we optimize that? So for heart, we actually do a CT scan, and we slow down the heart rate, and we put a little bit of a dye study in there, and we apply our artificial intelligence to it called a Clearly test. And the Clearly test helps us tell you how much plaque you have, where is it located in the three major vessels and the tributaries from there. And then also, is it calcified, which is mature healing plaque, or is it soft and immature and inflamed? So a calcium score is good information, but it's far from the whole story.
it's a part of the it's
It's a
just
part
another
of the
piece of
story.
information. Yeah.
And I would rather you have more calcified plaque and less soft plaque.
Yeah, cuz the soft plaque can
That's what's going to kill
eventually
you.
that's going to be the widowmaker.
That's going to be. And there's three major blood vessels: the right coronary artery, the left main and anterior descendant, known as the widowmaker. The dominant artery is the right coronary artery in 90% of people. So why is the widowmaker? Why is it the widowmaker? Is because where it's positioned, and these start in the aorta outside the heart and come back. So the pressure that it sees, the shear force, is the bottom part of your blood pressure. So now we get into blood pressure relative to your vein arteries in your head, into your heart, into your periphery. And then also about a third of the way down, it has a relatively acute, not 90 degrees, but maybe 75-degree branch that comes off that makes the blood swirl, that makes it more apt to injure the sidewalls of the blood vessel. So we see more plaque in that
In
vessel.
that region.
Correct.
Interesting.
So that's
Yeah.
why we see that. And so when we approach it, it is how do we decrease the accelerators? And Peter Attia likes to talk about a heart attack being driving off the end of a cliff, right? So what presses the accelerator? What takes your foot off the accelerator? What puts on the brake? What turns the car around? Right. And we know it's uric acid, blood sugar, we know it's cholesterol, it's types of cholesterol and all of those sort of things. And then we
Yeah.
can manipulate that to your advantage so that you don't accumulate more plaque.
Yeah. And it all makes sense. And then you take those exact things like you talked about, the blood sugar, and you realize, well, that's another one of the horsemen. That's type 2 diabetes. And you start to
Correct.
see that there's this all is intertwined. So if we have metabolic dysfunction, which is the biggest predictor of heart disease, what things do we look at as far as metabolic dysfunction goes? Because some people would say, oh yeah, my blood sugar is fine, or they may say, oh, my A1C was within normal limits. Maybe I'm pre-diabetic. I'm not diabetes. I don't have diabetes. That's fine. What's the way that you guys approach type 2 diabetes that may be different from
Well,
a traditional practice?
standard labs, just standard labs. We hemoglobin A1C, kind of the 2 to 3 month marker, what your average blood sugar is. First doctor I went to that was an anti-aging doctor, mine was like 5.7.
Hmm.
That's well within the normal. What he told me was, Jim, this makes you look good at Walmart, but this isn't good. Okay. He said, we want you 5'2", 5'1". We want it we want your average blood sugar to be probably in the 80s with less variable highs and lows. So we want a stricter band. Almost everything you can equate that's bad for humans health-wise can be made worse by more sugar. So whether it's cancer, whether it's brain disease, and Alzheimer's is called type 3 diabetes because of the breakdown of the blood-brain barrier and the way that we use sugar in that area. It's actually detrimental. And so that's a great start. But the metabolic disease that we see, high cholesterol, hypertension, or high blood pressure being raised, and high sugars together, almost always goes with obesity as well. And, and this is not body shaming. There are beautiful people that are heavy. They're not
Yeah.
healthy. They're not healthy.
Exactly.
And we cannot
Yeah.
equate that with health. That's going to be higher inflammation. And as we age, we know that there's aging. So just because we're more inflamed, we know that the fat holds toxins from the environment, all of those sort of things. And those are all part of what we want to control so that you don't age at a faster rate or that you don't spend 25 years in bad health, even though you're living. And we could argue how much living you're doing if you're in bad health for 25 years.
The other thing too is people won't even realize that they need to get on top of it, right? They're told they're
Correct.
healthy or they're within the normal limits.
Correct.
Well, if your normal limit is unhealthy, now all of a sudden you're sending the wrong message to people. Um, as
And that's what
far
we say
as
is optimal versus normal. So normal is
yes,
not optimal.
absolutely.
Yep.
Yeah. So optimizing where you are metabolically. Exercise,
Mhm.
clearly a major role here. Aerobic exercise, strength training, so keeping the heart healthy, keeping your mitochondria healthy with aerobic conditioning, but also strength training to give you the benefits of increased muscle mass, which one of the main things to increase that health span or those last 10 years of your life is to increase the amount of muscle mass that you're carrying into those last 10 years of life, because it's going to decrease no matter what. But if you decrease from a higher percentage, you're better off. Outside of exercise, you think about things like nutrition. Are there other factors that you look at for metabolic dysfunction out, or do you mainly focus on the nutrition and the type of exercise?
Nutrition has to be a focus, period. The problem with our nutritional supply is that it is not of the quality that it was 100 years ago. Depletion of the environment, the fact that we're using genetically modified sort of products, even for plant based foods, the fact that we have environmental toxins that are applied to those, or you have to transport them from South America to the United States. And by that time, they've lost some of their nutritional value. And so all, that is very, very important. But how do you do that? I think I read somewhere where the average apple now has a quarter of the nutritional value that it did 100 years ago. So you can do everything really well and just shop on the outside of the grocery store where most of the stuff is relatively healthy and not processed, but it still not be adequate. And back in my day, we were told if you took a bunch of vitamins, it just made it expensive pee.
Yeah.
Well, nowadays, probably need that just because we're not getting it in the regular diet in the United States.
Yeah.
Nutritional value is very low. So you got to start there.
Hmm.
Okay. And if you listen to Mark Hyman, he would be a great source of information related to diet.
Yeah.
And he's done a great job of exposing that to our whole environment. Anybody that listens to any aging or anything or just wellness, the nutritional aspects is important.
Yeah. And
Um,
that absolutely makes sense. It seems like we're in a world of fad diets
correct.
that are focused on particularly weight loss. Um, where I like to take a much more balanced approach. And a lot of this comes from my wife, who's a dietitian,
Hmm.
and she is anti-fad diet and instead has this opinion that, all of your foods you can eat and still be healthy, but it comes down to moderation. And then it
Mhm.
comes down to making sure that you're getting adequate nutrition, which if you have a super low carbohydrate diet and you're somebody that's very lean and a performance athlete, that's not going to be optimal for you.
No.
At the same time, if you're somebody that is eating a vegan diet that may avoid a lot of the really sugary processed foods, but you aren't getting enough protein, then that's not going to be advantageous to you as you're aging, like we said, carrying muscle mass forward. Is there a particular way that you approach diet, or do you try to really individualize it person to person?
I think it's gotta be individualized, and the problem with, in deference to your wife, nutritional research and nutritional science, is difficult because how do you keep people on a strict diet? Because humans will cheat. They're not gonna disclose. How do you can't stick them in a lab and watch them for 6 months and feed them only what you wanna feed them. But the other thing is there's so much ideology that's wrapped up in nutritional science, and then there's so many bad actors that benefit from having, the pyramid of nutrition being this way. Um, so you could say that, one person could do a carnivore diet and that could be a good diet for them, and it would be terrible for the next person. Um, and so we do try and make, I think Peter Attia talks about that. One of his things that he hates is if he goes to a party and somebody figures out he's an anti-aging doctor, because the first question he gets is, what should I eat?
Yeah, exactly. As
And
if
it's
there's
so
just a
complicated.
simple correct answer.
There's no simple correct answer.
Yeah.
But in general, having a more diverse diet that has a significant plant base to it.
Hmm.
And we talk about Mediterranean type diets, and then you can talk about which one of the 15 Mediterranean diets are we speaking about.
I want the Lebanese one with all the hummus.
There you go.
That's the one
Exactly.
I want.
So, I mean, and then the bottom line is people only probably have 15 to 20 things that they really enjoy and they cycle through it. So, how do we expand that, or how do we, it's much like working out. The first thing you do is, what do you like to do? What do you like to eat? Because you can expand on that. So that's why it becomes very personalized. And then your genetics also play into that. Um, and then where you're getting your food substance from, and there you get the nutritional value. I mean, the biggest thing if you're vegan is you're not going to have omega 3s. And omega 3s are can be very important for your brain health. They can be very important for your heart health. It can be very important for prevention of depression. Um, and so that's, and the other thing is if you're trying to get your proteins from plant based, which you can do, but you're going to eat more calories to get it. So it's not a lost cause. It needs to be to the point where you realize that it's an individual thing. And so one of the things we see is you got to maintain. Look, you can live without carbs. You can't live without protein or essential fatty acids. But most of our plants are going to be carb based, right? And so it's good to have that as well, and good to have the fiber. Fiber is huge. It's a prebiotic for your gut biome, which also keeps you healthy. Um, so there's a lot of things to consider. What it isn't is easy.
No, absolutely not. So
And
there with the nutrition being depleted
mhm.
and overall the minerals and vitamins in our foods being much less than they used to be, you talked about omega 3s. What are the common nutrition elements that you want to supplement or that you'll see that people maybe would benefit from adding to, say, their supplements or to their diet?
Yeah, so one of the first things that we see commonly is problems with vitamin B12 and folate. Vitamin B12 and folate is very important for your nervous system. It's what we give to women when they're pregnant so that you develop a baby with a normal nervous system. And so, like, if you do not have the gene to methylate B12 and folate, you don't activate the B12 and folate. And so then if you don't activate, you don't decrease things called homocysteine, which is an inflammatory marker in your brain that can cause you to have degenerative brain problems later on, or the lack of repair of your brain and the rest of your nervous system. So that can be important. Obviously, omega 3s can be very important. And in a very basic level, omega-3 levels of 8 to 12% of the total phospholipids in your brain, which the brain is 2% of your body weight and 25% of your metabolism.
Uh-huh.
And it likes fats and ketones. It
Mm-hmm.
gets a lot of sugar, and sugar is not as beneficial to the brain overall, especially as you get older. So
Yeah.
how do we maximize that? Well, we know that the omega-3s kind of make the cells soft. So the
Mm-hmm.
transmission is better, and it's electrical charged particles, chemical, where omega-6s and 9s kind of stiffen the cells relative. And so that's why omega-3s can be important for your brain.
Yeah. So if we go back to the B12 and folate, then is that as simple as taking a B12 and folate supplement? Or is there more specific things based on your levels of homocysteine?
Yeah, so homocysteine can be driven down
Okay.
with methylated B12 and folate, whether you do it yourself in your liver
Mm-hmm.
or whether if you're a poor methylator, you take it in the supplement. So it'd be
Okay.
methylcobalamin, methylfolate, as opposed to cyanocobalamin.
Okay.
So when there are products out there that might be called homocysteine supreme with the idea that you have pre-methylated B vitamins.
Okay.
And
That
that
makes
gets
sense.
past one of the major genes that we see was the MTHFR gene, which is you'll see ladies that have had multiple miscarriages and never really knew why, but because the nervous system of the fetus doesn't develop because they're not able to make active B vitamins, even though they might be
Interesting.
taking it. Yeah,
Interesting. So if you take the correct form,
take the correct form.
then you could in a basic science principle, you could then prevent that from happening.
Correct.
Yeah,
Correct.
interesting. So then if we go on to vitamin D,
Hmm.
that's probably the one that, when I was doing my training, I was at Cleveland Clinic. Uh, that is maybe the cloudiest place in the United States outside of like Seattle. I don't know,
Right.
but the amount of multiple sclerosis I saw there was significantly higher than whenever I was in Wichita or even here where I'm at in Arizona now. And so I would check people's vitamin D when they would come into inpatient rehab. Now, granted, on average, these people have been in the hospital for a couple of weeks already, so their levels they aren't getting vitamin D there, and they're having acute illness, so they're probably driving down their. But everybody was low. Everybody
Right.
was low on the scale of vitamin D, and I did some reading about it, and I came to the impression that our what we consider normal vitamin D may actually be low in general anyway, and these people were sufficiently like below that. So
Correct.
I would supplement the majority of our patients that were recovery because it just made sense from a basic scientific perspective if they're recovering from a prolonged illness. Now, if somebody's healthy and they're uh, vitamin D, it seems like that could be a simple way to help them function even better.
Yep.
And maybe they wouldn't even realize they're deficient. And once they do supplement, they would feel quite a bit better. What are your thoughts about vitamin D?
So vitamin D, fat soluble vitamin. Um, It is historically, we talk about using it to maintain bone health. It
Mm-hmm.
helps you with absorption of calcium, magnesium, phosphate for bone health, right? Well, it does two to
Mm-hmm.
300 things in your body. Okay. So we think of it almost like a hormone, even though it's a fat soluble vitamin. And we tend to recommend it along with K2 and particularly a active form of K2 called MK7. Um, what it does also is it potentiates your progesterone, and which
Okay.
progesterone helps you with testosterone. So it helps with lean mass. We know that vitamin D may have what's called a myostatin inhibition effect, which helps you maintain lean mass. We also know that people that had levels in the 60s, the 80s tended not to be hospitalized with respiratory COVID. So there's some interaction in an ACE receptor with people who have high blood pressure that take medications to bring their blood pressure down. They were more susceptible to getting respiratory COVID. So
Interesting.
I would tell you that the goal for us, the optimal range is 60 to 80 for vitamin D. If you look at the normal, it goes down as low as 30.
Yeah. Our normal labs at Cleveland Clinic were 30. And I
Correct.
always I always thought that was too low. 60 to 80
Hmm.
makes sense. And
Well,
you definitely don't see side effects
you
at
don't.
that level.
You don't. And so when you're talking about hormonal health, which you can
Hmm.
equate that to brain health, heart health as well. And then
Hmm.
if you talk about just bone health, we talked about also muscle health,
Yeah.
vitamin D is very important.
Yeah. And with
Um,
the ACE, so you talked about respiratory COVID. Um, with COVID causing an uncontrolled immune response in
Correct.
some people, and that's what led to the people that would then die from the respiratory inflammation due to COVID. Vitamin D, I initially thought about it as a strengthener of the immune system when in fact it's a modulator.
It's a
And if
modulator.
your immune system is not working enough, it can help it work a little more to catch up. Whereas if your immune system is going to be overactive, it can bring it
Yeah,
down to where it needs to be. And
absolutely.
that's a fascinating mechanism of something as simple as vitamin D, which we just associate with, well, you feel good if you're out in the sun, right? Or yeah, it
Correct.
could help with your bone health, but then you realize it's a much more complex chemical for the body.
And are you getting it in your normal nutritional supplements that you have or your food source?
Yeah.
Obviously, you talked about multiple sclerosis, a white matter disease, neurologic condition that we see more often above the 15th parallel.
Hmm.
And historically, and it's, MS or multiple sclerosis is the number one disabling disease of 50-year-old and less old women in this
Hmm.
country. So it is a very important thing because it takes people out of their ability to do what they want in society, job wise or just interpersonally. Um,
Hmm.
so, how much of that is related to B vitamins? How much of that is related to immune system?
Hmm.
And we don't clearly know what the initiation is, but we know it's probably multifactorial, and certainly vitamin D probably plays into that.
Yeah. And if you talk to, whenever I was at the Cleveland Clinic, I was fortunate enough to be in the same clinic as the MS experts there. And
Mhm.
these people were brilliant. I mean, they're world experts at
Absolutely.
treating MS because they're in Cleveland, Ohio. They're like the epicenter for MS.
Mhm.
And every single one of them said there's not a lot of definitive research on vitamin D because there's a lot of variability in the quality of studies that were done and
Mhm.
what levels are actually normal. But every single one of them said that it is definitely a component, and supplementing it in somebody with MS was basically non-negotiable for them. And it just in general, every one of them I asked, they said they did take vitamin D as a supplement.
Correct.
So that you could see what people think based on their actions, right? And so all of them taking vitamin D. I had another physician that I knew up there as an internal medicine doc, and he said he really felt bad. He was having a lot of fatigue and stuff like that, and he thought he really had something wrong with him. And he got basic labs done. He went to his own doc, and there was nothing irregular. And he actually was not a believer in vitamin D. He said
Mhm.
he had read the research when he was in training and just was kind of thought it was not as important. And his vitamin D level was 8,
Wow.
and he supplemented with vitamin D, and he said within a month he felt completely different, and he didn't even think that supplement would work. And so it wasn't like this is just placebo effect.
Well, and the other thing though is, first of all, we're talking about supplementing.
Hmm.
So, how good is the supplement you're getting?
Yeah.
Because it's not FDA regulated. And if you go to Target or Walmart or Walgreens, about a third of what you're getting actually is what it's advertised on the bottle.
Yeah.
You can go to third party catalogs, Whole Scripts, Full Scripts, places like that, where they do have pretty intensive third party evaluation. And these are people of quality control. Okay, but they tend to be more expensive, right?
Hmm.
Because of the quality of making the product. The other thing is it's fat soluble. So if you take it in the morning with just some water or some coffee and head out the door, you're not going to have the same potential to absorb it. So you
Yeah.
got to have some fats in there. So do you
Yeah.
take it with some olive oil? Do you take it with a meal
Yeah.
that has some fats in it? So there's that part of it as well, as opposed to the water soluble vitamins like the B vitamins.
Hmm.
Um,
And then the other thing too about vitamin D is that not everybody absorbs it the same. Obviously, your absorption is going to change as you age.
correct.
So to me, I always thought the best way to do vitamin D is to take a consistent supplement. Find one that you think is a good brand,
Hmm.
and then check your labs and see if it is improving and see if your level is getting to where you want it to be. Because
Correct.
then at least you're eliminating variables. But there's so many variables with how you absorb it and individual basis, and then of course the quality of the nutrients that you're getting in your diet, and then as well as the quality of the supplement, right?
Right. And I know my wife, even before I got into this field, she was a big advocate of consumer labs. You pay $10
Hmm.
a month. She would always, any kind of things over the counter, she would investigate that.
Yeah.
So she would make sure, that it passed their quality control as a third party evaluator.
Yeah.
Yeah.
Yeah. So if we speaking about MS, type 2 diabetes, all of this, let's go into neurodegenerative disease.
Right.
Okay, so with type 2 diabetes, really one of the biggest complications we see are how the sugar in your blood impacts the small blood vessels throughout your body, right? It can impact the blood vessels in your heart,
Correct.
lead you more prone to having clots there and heart attacks. It
Hmm.
can also impact the small blood vessels in your kidneys and cause kidney disease. It
Hmm.
can impact the small blood vessels in your eyes, cause diabetic retinopathy, or distally down at the end of your legs into your toes, the small blood vessels, and cause neuropathy there. Clearly this can have an impact on the brain as well, although that's not as easily established. But we know there's an impact. How do you go about screening for neurodegenerative conditions, and,
Yes.
and what does that look like?
We look at brain health in general. And so we do, as part of the whole body MRI, we separate that part out of the brain. We apply an artificial intelligence to it. We use something called Brain Key. Previously, we used something called C Neuro. And what that does is look at the size of the gray and the white matter. Then it looks at the white matter to see if there's areas of injury. The white matter has got a insulation around it called myelin. And in essence, those parts of the brains are sending signals long distance. So if it has an insulation around the cable, it can send it faster. And the gray matter is more local transmission. Little blood vessels come up into the white matter. If they get injured, then they light up on our MRIs. So they're called hyperintensities. Now, that could be MS if there's large areas of loss of white matter. We know that's a white matter disease of the central nervous system, which is the brain and the spinal cord, as opposed to the peripheral nerves that come out of the spinal cord. What else can cause these little injuries? Homocysteine being elevated, so it's inflamed. So a vasculitis of some sort. Migraine headaches can do it because it changes the way that you get oxygen to the brain. Sleep apnea, huge issue with that because you're not oxygenating, right? Flying at 8,000 feet, if you live at sea level and you're in a plane for 4 or 5 hours because you're relatively hypoxic. In the military, we put you on oxygen at 10,000 feet. So you can have some temporary injury that'll show up on our MRI if you have the ability to heal your brain. So that's phospholipids, omega 3s, B vitamins, then you can recover from that. And so that's why you want a constant state of evaluation. We can also look at shrinkage of the brain. So we look at gray matter and white matter together. That AI will give you a biologic brain age. After the age of 40, everybody's brain gets smaller. Okay. Within that, there's something called the hippocampus. The hippocampus is for short-term acquisitional new memories. And that's the part we many times will see affected by dementia. Other neurodevelopmental things like Parkinson's disease. Okay, well, what is the etiology of that? Is that genetic or is that environmental? And we think probably most of the time it's environmental due to toxins that can affect that area. But certainly, if you're not able to heal the brain because you have problems with blood sugar, you have small vessel disease, that makes it potentially harder to get rid of those issues. Um,
Especially in an area that's dependent
Dependent,
on small blood vessels to get there, right?
correct. So you can actually improve the endocalyx, which is this hair-like web that kind of protects the outside of the blood vessels. There's certain things that can do that. Some of them are supplements or something called arteriosil, which we see that can be helpful. The other thing you can use is you can use magnesium that crosses the blood-brain barrier that gets dilation of this because it relaxes smooth muscle. so you get more oxygenation. Sleep is going to be important, right? So deep sleep, having REM sleep. So deep sleep helps your growth hormone. REM sleep helps the lymphatic system of your brain kind of get rid of the garbage. Deep sleep's early on, REM sleep's later on. So if you have disruptive sleep patterns, you also tend to see more problems with the brain.
Yeah. So which also brings in alcohol,
Alcohol is a huge impact.
disrupts sleep patterns.
Correct.
Getting oxygen to the brain, sleep apnea, disrupts
Correct.
the sleep pattern. Marijuana use
Yep.
disrupts sleep pattern.
It can.
Anything that's going to take your brain from and prevent it from getting to that REM sleep, all of a sudden, that's going to cause some issues down the road. Not surprisingly, all of those are, at least alcohol and sleep apnea, are associated with increased risk for dementia and Alzheimer's later on.
Correct.
Yeah.
Now, I tell people all the time, well, the reason why I can't remember why I walked in this room is because of, that they think, oh, that's because my brain is shrinking. But I would tell you when you're 60 years old, your brain is like the Library of Congress. It's a lot harder to find a book than when you're 20 years old and you have a community library for a brain. It's just not that full. So all of us have a little bit of that. Now, when there's a problem is when your short-term memory is going. So that's when we start talking about the different dementias that are possible. And you can increase the size of your hippocampus. You can increase the health of your hippocampus. So those are things that we're looking at, and we're measuring those with artificial intelligence and finding out where you are relative to your age. And we can even follow. And I've definitely had people be in the 5% for range, and a year later, now they're in the 45%.
Yeah.
So, and that's just simply making sure that they're healing their brain.
Yeah. The interesting thing about the brain, right? Everybody looks at the muscles and knows that you can do enough exercise and make your muscles bigger, and you can improve the strength of your muscles. I think people tend in general to think that you can't improve the strength of your brain for whatever reason.
Hmm,
And the funniest thing is that we actually know this, that you can actually strengthen the brain and cause hypertrophy of certain areas, like chess players having higher hippocampal volumes
correct.
than the average person. And not shockingly, they have lower levels of neurodegenerative diseases.
Correct.
So,
So one of
you
the
know, you
recommendations
can change it.
and we always so Alzheimer's prevention, which we'll lump. I mean, there's different causes of dementia, which Alzheimer's is a type. But we know that learning new things. Now, that doesn't mean if you're great at crossword puzzles, you keep doing crossword puzzles because that's doing the same thing over and over and over. But learning new things seems to be helpful. Diet and exercise is important for your brain health. Maybe more important is social engagement because that's talking to other people, that's learning new things. The joy, the endorphins that you get from being out and about and those things. So one of the things we saw during the COVID, of course, was a great increase in the impact of dementia because people were locked in their homes. And there's some belief that if you took exercise, diet, and social engagement, but you could only pick one of those, you would choose social engagement for prevention of Alzheimer's.
Well, you see a lot of cultures where their diet may not be perfect and they don't do a lot of exercise, but their social engagement of their elderly is extremely high. It reminds me of that Netflix series about blue
Blue
zones.
zones,
And there
absolutely.
was Okinawa, Japan.
Hmm.
The elderly folks there had jobs. They actually did things. They participated in the family multi-generational households where the 93-year-old grandmother may have received some help from everybody else, but they also provided health and it gave them purpose. And honestly, it made me think of Charlie Munger
Yep.
too.
Yep.
Charlie Munger was sharp as could be until the day he died. And when you looked at him, that guy did not exercise.
No. No.
that guy, that guy was. I don't know if him and Warren were stopping at McDonald's every day, but I know Warren was, and I'm sure he would every now and then. But he was engaged until he died, and
Correct.
surprisingly, you could hear him talk a month before he died, and you were like, "Wow, this guy's still extremely sharp." Shows the importance of the untestable or unstudyable things like doing hard things, staying socially engaged, because you can't just quantify it into a number.
Correct. And
Yeah.
so I will tell you that's one of the decisions for me to not want to retire.
Yeah.
And it's I have the unfortunate opportunity to find out I have all the bad genes for Alzheimer's, even though nobody in my family has dementia. So my grandmothers lived into their 90s, my grandfathers into the late 80s, no dementia, but I
Yeah.
obviously have it on both sides of my family.
So now you just can't stop working.
Well, that's I can't stop thinking.
Yeah.
Um,
Well, your wife's going to love that.
well, it's yeah, exactly. 'Cause she's very, very concerned about stimulating the economy.
Of
So
course.
it helps if I stay working. Um,
Yeah.
so we
I just hope you own stock in Nordstrom. So
so I mean, but that was one of the determining factors. It was like, look, I moved to a 55 and older community because if I do retire, I want people around me that are active. I want,
yeah.
people that are getting together. I want things to do.
Hmm.
I don't want to sit at my home with my avocations, which may be just sitting reading a book, because I certainly could do that because I love to read.
Yeah.
Uh,
Or even worse, watching the news.
or watching the news is exactly
Yeah.
right. So, um, so I mean, those kind of things are important. Now, there's plenty of episodes where we see like groups of nuns in their 90s that have all the bad genes for Alzheimer's, and they don't have any of the implications of dementia. That's because they're doing something daily, they're learning new things, they're studying, they're doing things that are worthwhile for them. And so we definitely see that. But, you couple that with somebody who's socially withdrawn, who's got diabetes, who has high blood pressure, who may not have the genes for Alzheimer's at all, but they end up with severe dementia. So if you have a brain, you can become demented. If you have all the bad genes for Alzheimer's, you can avoid ever having Alzheimer's. And that's the thing is, but it's best to start that early
Yeah.
and to know
Yeah.
what you're up
Because
against.
like you said, the interventions don't work as well after you've lived out the bad side of things for 50, 60 years, right?
Correct.
The interventions are less effective and they're more effective early on,
Which is back to the
which,
whole idea of changing our sick care system to a system that addresses it on the front end and not the back end.
yeah, absolutely. Which brings us to cancer.
Yeah,
Perhaps the ultimate sick care system disease, collection of diseases. Cancer is something that we have tools that we can screen for. We have aggressive screening techniques that could be used. And for some reason, we choose not to based on financial
correct.
viability. And so this is one of the big ones that seems like we can get ahead of and prevent. And we have the tools to do, but we are choosing not to because of how our financial healthcare system is, is structured. So how are you doing things at Fountain Life that makes more sense for
So the
preventing
first thing we
cancer and
do
getting
is
ahead of
we
it?
do a screening test looking at the 50 most common cancers, which 5 years ago we didn't have. And that's called a Grail-Galari test. Grail-Galari test is looking at methylation patterns of DNA of cancer cells that are in your blood. So, of the top 50 cancers, it's really good for about 35 of them. And mainly, it's really good in places between your mouth and where you go to the bathroom. So, your pancreas, your gallbladder, your liver, your bowel, your rectum. And it can be upwards of in the 90 percentile for sensitivity. So really good. Now, where it does not do as well is encapsulated organs where the cancer has to break out of it. So it's not great for thyroid. It's not great for your bladder, for your uterus if you're a female, for your prostate if you're a male. So then what we do is we look at other things. One of them is to do a whole body MRI. So kidney is one of the places that you may not have cancer show up on the Grail test until it busts out of the capsule of the kidney. So when we combine those together, we're finding about 2% of our population that comes through has an unrecognized cancer that can be found early. Okay. Um, Breast cancer, it's about 30% sensitive. I'll give you an anecdote. We had a lady, She is a physician by background. She's relatively young in her 40s. Reason why she came, I just know I have cancer. I just feel I have cancer. So she had an intuition about it. We did an MRI. We saw an area of one of her breasts that was concerning. So I called her right away. We didn't even have the Grail test back yet. She went the next day and had an ultrasound with a fine needle aspiration. Was told it was scar tissue, not to worry. We got the Grail test back the next day, and it was positive for cancer. She actually would have had a biopsy 2 days later, and it was cancer. So, if you think about it, if you have just stopped at the ultrasound, we didn't have the Grail test, would have been told, "Hey, you don't have to worry. This was negative." It was just so that tells us the sensitivity of our doing our fine needle aspirate.
Well, I mean, you think about you do a lot of that. You've done a ton of ultrasound.
Correct.
I do a lot of ultrasound. That is a large that is a very difficult skill to master, and you could definitely, if a small enough target, miss getting that aspiration.
You
I
can.
wouldn't blame the person doing the test. I think it's more of just the nature of the test and the limitations of the technology, right?
Absolutely, absolutely. Don't blame that person, but imagine how reassuring that was to her initially. "Oh, this is negative," and then take you back emotionally the other way. "Oh, now this test is," but, she came to us with the premonition that she had cancer, with the medical background, and it turned out that she did, and so she's had to go down the road of treatment, but the good thing is it's early on. They've
And
done
it's
the
not
genetics
metastatic.
on it, so they know it's estrogen versus non-estrogen sensitive and all of those sort of things. So she's actually
Yeah.
got it while it was early.
Yeah.
But the
I think
MRI
the
showed that, and the CAT scan showed it.
Yeah. Well, I like what Peter Attia talked about with the cancers, treating them. And we haven't gotten really good at treating the cancers that have spread. We've
Correct.
gotten good at treating the cancers before they spread.
Absolutely.
And so if we can't treat the cancers after they spread, our goal should be to find early detection, just like
Absolutely.
that, and the survival of somebody before they spread. I mean, particularly, you always think about pancreatic cancer when that one's found. It's
Huge,
typically spread everywhere. So
huge.
if you could just say, hey, listen, all right, we haven't found a way to cure this. Let's be more aggressive about preventing it. It makes sense that in the future there will be more aggressive. What was the test called that you were talking about that screens for the 50 types of cancer?
Grail, Galari, but Grail
Grail
test.
Galari.
If you just went with
Okay.
Grail test, it's the same. And of
Yeah.
course, now the goal is to figure out how to do that for the encapsulated organs. How do we screen from that on the
Yeah.
front?
But a lot of those encapsulated organs we already have pretty good screening tests for. Like a thyroid, for example, we can ultrasound that and image it pretty easily.
Yeah,
So there those tests, prostate, we have some pretty good tests for prostate cancer too. So
but you can
those are something
actually
that we
look
have
at
a
the prostate with an MRI, and you can look at, cross section, and you can look at different views, and you can actually see that there is morphology differences within it, and then you can couple that with something called a PSA test. And if it's a high number, you can, or the density of it, you can look at that, but you can also look and see whether it's capturing free PSA. So a high PSA number and a low free PSA number bad until proven otherwise. That's kind of the direction that we go in. So that's part of it. We've had 2 or 3 people that have had thyroid cancer, and what we found is on the MRI there was a nodule, and 2 of them are physicians. And so did not have any idea that they had any thyroid problems. They'd never really had any thyroid problems. This is unrelated, and it was found on MRI incidentally. So the whole body MRI would be one of the things we recommend that people get regularly. And you could do a whole body MRI financially. We could probably do it at about $600 a year. So why isn't that approved by your insurance company?
It's crazy.
Correct, correct. And
Yeah.
so even if your deductible didn't cover it, it'd be worthwhile to have that as a screening test.
Yeah. Obviously I treat a lot of back pain.
Mhm.
And one of the things that just blows my mind is the limitations to get an MRI for somebody that's absolutely miserable to wait 6 weeks to get an MRI. we have some agreements with people where we can get them into an MRI for a couple $100
Correct.
for a lower back MRI. And so this technology is just becoming more and more available. What's scary are places like Canada, where they have put laws against ordering whole body MRIs and stuff like
Correct.
that. And they legitimately won't allow their physicians to screen for different things like this.
Well, the interesting thing is we have a lot of patients that come to us from Canada that are financially able to come because, they haven't seen their primary care doctor in 3 years since COVID started because they're not seeing people in their clinics. So they haven't had a physical. They've had blood work done, but again, normal versus optimal. Um, and lucky for them, many times they have second homes in the States, and so they can do that. But what about the rest of the people up there? I mean, the typical sort of socialized medicine system, where we get a lower standard of care for a greater number of people.
Yeah.
Um,
And then you end up developing a two-tier medical system.
you do.
And the Cleveland Clinic opened a location in London,
Yep.
and they expected that location would take a little bit to get going. What happened is that hospital filled up right away with people who wanted to see the specialist, who took out private insurance so that way they could come there. And Cleveland Clinic is expanding their London location already.
Correct.
And that's
Correct.
not a surprise. It's not a surprise. People know that are starting to realize that this type of care is available, and they're just going to want more of it.
That's true. And, our original chief medical officer was a cardiothoracic surgeon from Cleveland Clinic in Dubai. So he was at Abu Dhabi, Rakesh Siri, brilliant cardiothoracic surgeon that became the CEO of the Cleveland Clinic over there. Has since left, domestic reasons why. We're looking at expanding to London and Toronto, and places like that, now. So they've been looking at that for a couple of years, but the constraints of taking care of people who live in Canada is great. DAGA, a simple supplement in the United States, right? For your adrenal gland to help you with some of the precursors of your hormones. That's a Schedule II drug in New Zealand, Australia, and Canada.
It's
So,
crazy.
but you can buy it over the counter here in the United
Yeah.
States.
Yeah.
So
And then you could go, then if you really wanted it, you can go down to Mexico and get whatever you want.
whatever you want. Exactly right. And it's interesting because we also have patients that live in the States, but their moms and dads were Mexican and they lived near the border and they
uh,
were raised on antibiotics.
yeah.
So you want to talk
Yeah. They
about,
just get antibiotics for everything.
yeah, so your gut is destroyed. Typical gut problems later in life is somebody that was born by cesarean section, who was not breastfed, who had lots of antibiotics when they were younger, and their gut biome was destroyed, and then they have ulcerative colitis and all these other kind of things that we see later in life. So, the the treatment for bad bacteria in your gut is not antibiotics. It's build up your good bacteria.
Yeah. It's biotics.
It's biotics, exactly
Yeah.
right, and short chain fatty acids, which kills the opportunistic. And in our line of work, how much of these swollen joints that we see, where we
Hmm.
don't see any arthritis, and we end up sending the rheumatologist, how much of that is Citrobacter and Klebsiella that's gone through the gut wall and is circulating and ends up in the joint?
Yeah.
You
So
can,
how do you treat that?
yeah, and so you go back to treating it in the gut best you can. Now, if you use antibiotics, you carpet bomb the gut. So you're taking away good and bad bacteria. You may have to do that to help with SI joint problems, sacroiliitis, to get rid of the Citrobacter in the joint, but you've got to replenish that gut biome with good bacteria.
So is there a probiotic that you recommend?
Yeah, I actually there's something called Dr. Harari, Ohhari. It's a prebiotic, probiotic, postbiotic. And so prebiotics so feed the good bacteria. Probiotic, it has a blend of a balance of the good bacteria. So the problem isn't just throwing more and more. Believe it or not, large numbers of good bacteria many times is not great, which means you're overfeeding it. They may not work well. And then Postbiotic is what you do when you digest the food and how you absorb it. So this is a blend that has been fermented for 5 years and then encapsulated. The capsule is very thick and small, gets it through the stomach, through the small bowel, and into the large bowel before it is going to, release its post, and probiotics. So,
Okay.
so I like that one.
I just looked it up.
Yeah. So the
I'm gonna have to
interesting
give it a
thing
shot.
is when you look at the numbers of it and the amount of probiotics it has, it fails consumer labs because it's
Oh,
not a
interesting.
huge number, it's a balance of number.
Hmm.
And then there's another one in there that if you have acromantia, which is low. So acromantia will be killed with oxygen. So we didn't know about it when we put it on petri dishes, but once we could look at DNA of bacteria, we found out it's real important. It actually has a GLP-1 effect, almost like the semaglutide and the tirzepatide, the Ozempics and the Mounjaro that we're using. It also is one of the main bacteria that there's a snot-like lining along your bowels, right? It protects it. Well, you also have to get rid of the old snot to put down new, and Akkermansia is one of the major components of that. So if you're not doing the gut biome testing, you may not know it. But how do we stabilize it in air? So there is a company called Pendulum, who a biochemist who's there. She came up with a way of stabilizing it so that you can take it as a probiotic as well. So those are the things we do, and then you need to prebiotics are what feed your gut bacteria. So fermented foods, polyphenol foods, pomegranates, raspberries, things like that. Fiber,
Kombucha.
kombucha, fiber.
Love kombucha.
So you
Love
need
fiber.
you need fiber, and some
Yeah.
people bloat with fiber. They don't really like it, but there's things out there that don't cause as much bloating that are digestible fiber. There's a Sun Fiber brand that does well with people. And then there's this whole idea of, irritable bowel syndrome, which is like the fibromyalgia of the bowel, which many times can be due to people have had food poisoning and they have subsequent bacteria in their small bowel where it's not supposed to be. And how do you get rid of that? So probably 60% of irritable bowel syndrome is related to that, but we don't identify it. And if you go to a GI doctor, they're going to tell you have irritable bowel syndrome. This is like you and I telling you have fibromyalgia, which is
Yeah.
not really a diagnosis.
Yeah. It's just kind of like, yeah, that's the symptom.
That's a symptom,
The bowel is irritable. Yeah.
not the why, it's the what. And we can
Yeah.
give you medicine because we have plenty of medicines for it, but it's not discussing the why. It's not getting rid of the why. Yeah. And so those are some of the things we look at.
So those are the four horsemen that we talked about, right? Heart disease, cancer, neurodegenerative diseases, and then of course metabolic dysfunction. Well, four horsemen, they're all kind of tied up into one big bad thing. They're all influential on each other.
Correct.
What do we do as far as optimizing people's
Yeah.
lives? We can prevent death, but if we prevent death for a poor quality of life, are we really achieving that much? So, what can we do to optimize people's lives?
Yeah. So for optimization, first of all, is it's going to be body habitus, your muscle versus your body fat, your nutrition, supplementation that we think takes away inflammation, which is a big thing for aging. And then you can even look even further. You can look into biologic clocks, which shows them how well they're doing, and also genomic precursors or predispositions that we look at as well. And so, and that's one of the things, luckily you're of the age when genetics and sequencing DNA was present. When I was in medical school, it was still four squares and fruit flies,
Yes.
And so, and most people don't understand genetics and epigenetics.
Uh huh.
And so what I tell people is you got 3 to 3.5 billion genes in your genome, which we can sequence now 4 to 5 weeks, about $500. So you can do that, and probably this time next year it'll be $200 to $300. It might be 2 weeks, and eventually, is you're going to be able to be getting it in the same day. But most personal thing you probably own is your genetics, right? You don't want the rest of the world to have it. You don't want insurance companies knowing it, all that kind of stuff. Um, But what we can do is I tell people you've got this many genes and they're basically wrapped and swirled into 23 paired chromosomes with a cap on it called a telomere, which people in anti-aging, they talk about the telomere links. And every time you divide cells, you lose a little bit of the telomere length on those divided cells, and eventually they lose their telomere cap. It's kind of like the plastic on the end of your shoelace. You lose that, then that becomes older, and you need to get rid of it. So that's the autophagy, self-eating, get rid of the old. The reason is, well, every cell in your body has the same DNA. Well, how come your eye is different than your hair is different than your liver? They would be the same, right, if that was the end of the story, but there's something called
Exactly.
epigenome where you're reading it and you're telling it what to do, almost like toggle switching. You're gonna be expressed, you're not. So when I tell somebody that they have all the bad genes, the predisposition for heart disease, and they're in the 97th percentile, which means that the risk is gonna be 30%. Well, they don't understand that. Why? I thought it was 97. No, your epigenome has much more influence over the expression. There's maybe 40 or 50 predeterminate things from DNA, like cystic fibrosis, Tay-Sachs disease, muscular dystrophy, things like that. So everything else is predisposition. So what you do influences the epigenome, the extrinsic influence on the epigenome. So extrinsic outside your body.
Yeah. And
In
that's the variables that you subject your body to, right?
Correct.
So
And that
I would imagine exercise, nutrition, sleep, all of these things, challenging yourself, like we talked about earlier, all
huge.
play huge roles in that, correct?
They do. And I think of all the stuff that you hear about the cold plunge, the saunas. I kind of explain it to patients in this way. Ancestrally, we had heat stress, we had cold stress. We didn't live in 72 degrees, right? We didn't know when we were going to eat, depending on when you hunted it or gathered it. So you might go 2 days without eating. So that's intermittent fasting. And there's something called mTOR, which is an anabolic kind of thing that you bring in your body. And we live in a feast state. So we eat 3 meals a day. So exercise is what we used to do ancestrally. We don't do it as much now. Okay, well, mTOR is like you get 14 deliveries from Amazon every day, and all that's coming into your house, but nothing's going back out. Eventually, you have a hoarder home, and that's what your body becomes. So, part of anti aging is getting rid of the mTOR and controlling the mTOR and basically cleaning up. And that's where everything we're doing is basically because ancestrally, that's what we were made to experience. And so that's where all of these things come in. And we know that it makes you overall younger when we look at your telomere age and we look at your what we call your epigenetic aging. When we look at biological clocks.
And does that have to do with methylation at all?
It does. And they're
Yeah.
looking mainly in the newer clocks at methylation patterns of the DNA of aging cells. So the probably the one that's used the most in research now is some called the Dunedin Pace Scale. Um, and the Dunedin Pay Scale, they've been looking at people in Dunedin, New Zealand through Duke and Columbia University for 50 years. And then about 15 years of observation of the DNA methylation of the DNA of aging cells.
Yeah.
So they come up with a pace of aging. So if you're aging 365 days a year, in 365 days, your score is a 1.0. And the place where people most probably identify with this right now is a guy named Brian Johnson, who came up with a blueprint for aging. And he has a rejuvenation Olympics through a website where he's looking at the best improvement of your Dunedin pay scale. Second or third generation clock looking at methylation patterns.
Yeah.
Yeah.
Unfortunately for Brian Johnson, he kind of looks like a vampire, so he's going to scare a lot of people off.
Well, and obviously he's on the spectrum a little
Yeah.
bit.
Yeah.
Um, he got down to 3% body fat. Now he's about 7%. He found out that that was not healthy.
I was just
Um,
about to say 0% body fat is probably death. So
correct. Correct.
maybe there is a lower limit to what you want to get to.
We can argue that less than 7 is probably not healthy in a male.
Yeah.
Um,
Yeah. And
you need
in females, when they start to get lower in body fat, what you see is they lose their menstrual cycle.
They do.
Clearly this is not a healthy level to be at if you're below
Not a
that.
healthy level. Right.
Yeah.
And
But
we could argue for heart health, the number one thing that women have is their hormones. And then we get a whole discussion about hormones after menopause
yeah.
for
And
that.
this is something that you can optimize,
You
right?
can optimize it. And believe it or not, I have a whole cohort of patients that I put on physiologic restoration, which basically I'm simulating what they were when they were 25. So I'm
Hmm.
increasing their estrogen in the first half of their cycle, adding progesterone in the second half of the cycle and having it come back down rather than just giving them a cream or a pill where it's the same every day, which is not
Yeah.
physiologic.
It's not physiologic at all, right?
Correct. And
Yeah.
so that would be an optimization of hormone. And we know that women's hormones keep their brain healthy, keep their heart healthy, keep their bones
Hmm.
healthy. And we could talk about the Women's Health Initiative from the early 2000s and the destruction to a whole generation of women's health that has occurred
Yeah.
because of that.
Well, I think it's a good thing that we're coming away from that.
Yes,
Let's put it that way.
absolutely.
There's a lot of people that are realizing that was maybe the wrong assumption to just take the results. For those who don't know, the Women's Health Initiative showed that there was a increase in cancer risk among women who were on estrogen, but what it didn't account for was the relative risk was, I believe, at 25%, but the absolute risk was 1 in 1,000
Yep, you
increase in
got it.
cancer.
So the
Yeah.
group that had the cancer had a uterus and they got synthetic estrogen, synthetic progesterone, progestin. Not bioidentical. Bioidentical means exactly the same construction of, chemically as what you would have in your body. So it was a group with progestin and estrogen, and they went from 4 to 5 breast cancers per thousand, which is
Hmm.
24%, or 1 in 1,000. Now, the other group did not have a uterus, so they didn't have progestin. They just got estrogen, and there was no increase. So it wasn't the estrogen, it was the progestin, if you want to look at the results. But they stopped the study and they basically put it in the mainstream media and they said there was a 24% increase in cancer if you were taking hormones.
And that was it.
That was it. And many people
Yeah.
never read the study.
Yeah.
And so now it's all over the mainstream media. Doctors are saying, oh my gosh, I'm not going to give any of that. And there's still plenty of doctors that exist
Yeah.
that have not scrutinized that
Well,
report.
and look at the second order effects too, right? One of the biggest things for decreasing health span among women is going to be compression fractures and osteoporotic
Oh my
fractures.
gosh.
And
Yes,
they are miserable.
they're
A
miserable.
compression fracture is one of the most miserable things that could probably happen to you.
And that's the
And
first fracture we see in somebody who's osteoporotic.
yeah.
You
And
know,
it eventually takes somebody who was functional and now they're hunched over, they can't see as well, they're higher risk of falling, they're already osteoporotic. If you could if you look at the second order effects of estrogen and decreasing the osteoporosis rates in women and decreasing fracture risk, all of a sudden you can easily say, that extra 1 in 1,000 risk is worth it.
absolutely.
Yeah.
Absolutely. And again, you said the relative risk, 24%.
Yeah.
Absolute risk, 1 in 1,000. If you explain that to a patient, that you have a 1 in 1,000 increased chance if you're taking a synthetic progesterone,
Hmm.
which they don't even use in Europe,
Yeah.
and you had bioidentical, almost everybody would jump at the chance to preserve their bones and their heart and their brain.
Yeah. It
It's an easy
absolutely makes
decision.
sense.
Yeah.
Easy. Yeah.
So that's one of the things we try and optimize. And we believe that you can take hormones as a woman the rest of your life. There's not a 10-year. Now, there was some concern because they saw more heart events in somebody that hadn't got hormone replacement within 10 years of menopause. But that's because they used a synthetic, which caused an enzyme to basically loosen up the plaque so it would mobilize.
Yeah.
And so, we don't use synthetic hormones as a rule.
Hmm.
We want to use estradiol, not estrone, as a
Hmm.
rule. We want to use bioidentical progesterone. And if you use it right, you don't really have to add testosterone in because that comes from your progesterone.
Yeah.
And we also know that oral estrogen in pills goes through the liver. The metabolite causes inflammation. So we see a rise in your highly sensitive CRP. Well,
Yeah.
what are we trying to do for anti-aging is lower your inflammation.
Yeah.
So those are
So
ways of optimizing.
yeah, and that makes sense. So we basically have preventing and optimizing, two things that traditional medicine is not exactly focused on. There's a
Correct.
little bit of more of the prevention now, but definitely not the level that we can do it successfully at. And so with preventing, we're preventing the four major horsemen, as Peter Attia talks about: heart disease, cancer, neurodegenerative disease, metabolic dysfunction, or type 2 diabetes.
Correct.
Optimizing, we're looking at making you live better for longer, increasing that health span. And the way we're doing that is looking at epigenetic age, using lifestyle modifications, and then checking your like important labs and seeing what we can replace or what we can do from a medical standpoint to allow you to optimally function, right? Like we talked about with the hormones.
Correct.
um, is there anything else that you want to include that you think our listeners would take benefit from?
Well, the other thing is that if you have problems with joint health and things like that, or in general, we do know that some of your own stem cells and/or what we call exosomes, which are nanoparticles of your platelets, and platelets are medicinal signaling cells to bring your own stem cells in. That those can be important for decreasing inflammation and helping you feel better as well. So that's an aside. But going back to the original discussion and our mission statement, it's going to be prevention. It's going to be data driven. So we have to collect the data.
Mm-hmm.
One of the things that we're going to do is, we'll have an app, we'll have a way that you can put your monitors for blood pressure, also your sleep and everything in as well. We can see that the implementation of certain things are making a difference on the back end. So that's data driven as well. And it's optimization to improve your health span, to increase your longevity. But more important, nobody wants to live a long time if they're miserable. So it's really increasing your health span. And ultimately, the goal is that you die as young as possible at an old age. That's the goal.
So where can the listeners find you at? I know Fountain Life. Is it fountainlife.com, I believe,
Yes, sir.
is the website. Locations in several different areas across the United States,
Yeah, right now
correct?
we have Naples, Florida, Orlando, we have Frisco, Texas, Dallas, and then we have New York, just outside Westchester, New York. Um, Breaking ground soon around the Boston area, um, Toronto, London, Santa Monica, looking at Athens and a little bit further up the coast in Greece. So there's different places, definitely, but the goal is not to have brick and mortar. The goal is to democratize this to the medical system. So we actually have Fountain Health, which is an insurance that actually allow you to get these testing done. So that's called Fountain Health. So prevention, having the brick and mortar, having it democratized to the whole country so that everybody can do that through an insurance program. And then IT part, or Fountain Digital, which is to come up with a platform where we can actually look at how well people are doing over time and collect the data.
Okay. And then other resources that people could listen to or check
Yeah.
out. I think Outlive by Peter Attia is something that we've already
I always
met.
always recommend that. If you're going to listen to podcasts, I like Andrew Huberman. Huberman Labs has some very very poignant, very good discussion. There's a Vitality Radio, which is a non-physician, but he has a lot of great information, great people on there. So that's Jared St. Clair.
Mm-hmm.
And then I certainly like Gabrielle Lyon. She comes from a muscle centric point of view for health and longevity, which is what I ascribe to because I'm physical medicine and strength and conditioning. So the best way for longevity and well span to me is make sure that you keep your muscle. And we know that you can make muscle the rest of your life, even into your 90s. Remember, that's Walter Frontera. PM&R used to be at Harvard, and we know that even 90-year-olds can make muscle if they have a resistance exercise program.
Yeah, and that's something that I think people would be shocked by. But you can see it, and there's plenty of case studies out there of older people that have increased muscle mass, and so it's definitely possible.
Well, we
Can
have
definitely help people.
70-year-old women who've never lifted a weight that are now, because of their osteoporosis, lifting very heavy weights, few reps,
Uh
but
huh.
they've gotten very powerful, which stresses the bone. So you can
Yeah.
reverse osteoporosis. OsteoStrong is one of the examples, but there's many people that are now have osteoporosis programs with a resistance exercise. But Rashid Sanaki and some of the other people back in the late 90s and early 2000s, they would tell you to play golf. Well, that's not
Yeah.
really stressing the bone the same way.
That's just because they just wanted to play golf.
Well, that could be, but
Yeah.
we definitely found the extension-based program and walking the course was helpful for people.
Yeah.
So
Yeah.
early on, but if you want to be frustrated and miserable, learn to play golf. I'm just
Yeah,
kidding.
exactly. Especially if you golf like me.
Exactly. So, but I mean,
Uh,
move. It could be simple things. If
mhm.
you watch TV, every time a set of commercials comes up, just get up out of the seat and do a squat back into the seat.
Yeah.
Do an L sit while you're sitting in a chair. Bring your knees up and bring them back down a couple of times. These are things that you can do. Tai Chi is
Mhm.
wonderful as we age. It's very gentle to your joints, but great for your core and your muscles and your balance. There's
Yeah.
lots of things that you can do, but I would tell you that one thing you've got to do is you've got to move.
Yeah.
Yeah.
That's
And
the single
so,
biggest interventions is moving.
correct,
Yeah.
correct. And so it does go back to diet, exercise, having the right, amount of things to rejuvenate you and decrease inflammation.
Mhm.
And then hopefully we'll get more and more granular. We can even get into, what improves your biologic age. That can be medications and things like that, rapamycin, all these other kind of stuff. But those are down the level. The basic thing that people should be able to afford is to eat the right foods, keep their body fat down, keep moving,
Yeah.
and then sleep well
Exactly.
and get to sleep.
Awesome. And social interaction, of
Oh,
course.
and social interaction. So
Yeah.
go to the grocery store and talk to the people about what they're buying.
Yeah, exactly,
Yeah.
exactly.
And then ultimately is also, I hate to say it, but if you ever take an environmental toxin course, the
Mhm.
first thing you do is you come out of there and it's like, I'm not breathing, I'm not touching anything, I'm not eating anything.
Yeah.
My glutathione, I need to raise my glutathione as high as possible.
Yeah.
Um, but there's even the good things around the periphery of the grocery store. You probably need to wash it because they spray it with lipid
Mhm.
particles to keep things like glyphosate or Roundup or organic phosphate. So having clear dawn and kind of having a mixture of 1 to 10 water to clean your vegetables, avoidance of prepackaged lettuce, which is probably a number one source, especially the bean sprouts, number one source of getting food poisoning. Um, so those things are important as well. Um, so those are all things that you can do, but a lot of it is down the pike. The big things: eat well, exercise. Make sure that you're getting things looked at, and you want to prevent it on the front end. And hopefully, we can democratize our healthcare insurance companies to take the emphasis on that as well.
Yeah, and that absolutely makes sense. Well, I think that's a wrap, Dr. Bowen. I think we've had an extensive conversation on this today. Thank you so much for coming on here. This will not be the last time, hopefully.
Well, and
And
Nolan,
I would,
thank you. And I'm going to tell you that I love what you're doing. And it's great to see you at this part in your career, having seen you back when you were a college student and everything. And you definitely are one of the people I know that has the IQ, EQ, and SQ to revolutionize medicine. And I'm looking forward to see what you do as I age.
well, I appreciate it, Dr. Bowen. If anybody has any questions, leave them down in the comments and let us know. Next time we're on here, we can answer them. And thanks again. This is the Prescription Press. I'm Nolan Fisher. My guest today was Dr. Jimmy Bowen.
Thank you.
Thanks for listening.